Ladies and gentlemen, welcome to Cardiovascular Education channel. My name is Dr. Aurangzeb and today I am going to discuss a very interesting and intriguing topic, that is switching platelet P2Y12 receptor inhibitor therapies. The reason I chose this topic is because that increased number of patients are being treated with dual antiplatelet therapy for indications like acute coronary syndrome and patients who have undergone PCI. Yet, while the patient is on dual antiplatelet therapy, different clinical scenarios might arise which might compel you to switch the different agents. I will try to make this topic simple because it's a bit complicated, so that it is easy for you to understand, not only for your board purposes, for your academics, but also will help you to easily treat your patients with whom you come across in your day-to-day practice. So without any further delay, let's begin our topic. Before proceeding, I will request you to please subscribe to my channel. Also, if you have any queries, if you have any questions, please drop them in the comment box and we will try to answer them. And also I would like to request you to like and also to share this video. This is the outline of my today's presentation. I will go through briefly introducing the concept of dual antiplatelet therapy, what are the pharmacological properties of the various agents used, what are the different switching modalities, some important definitions, expert consensus on switching, some special considerations and clinical scenarios, and take-home points. We begin our discussion with the introduction of dual antiplatelet therapy. Aspirin in combination with P2Y12 receptor antagonist is referred to as dual antiplatelet therapy, and it is used in patients who have had an acute coronary syndrome and patients who have undergone PCI to reduce the various atherothrombotic adverse events. The P2Y12 receptor antagonists include CLOPIDOGREL, which is the only agent used in stable ischemic heart disease patients, TICAGRELOR, PRASUGREL, and the intravenous agent cangrelor. From the guidelines, we also know that ticagrelor and prasugrel are the preferred agents over clopidogrel in acute coronary syndromes. You might come across different clinical scenarios that require switching. The availability of different oral P2Y12 inhibitors has enabled physicians to contemplate switching among therapies because of specific clinical scenarios. The recent introduction of an intravenous P2Y12 inhibitor, cangrelor, further adds to the multitude of modalities and settings in which switching therapies may occur. Some of the factors contributing to switching: clinical settings, which we will be discussing further in a bit detail; patient characteristics, for example, elderly patients, patients who have low body mass index, or concomitant therapies like oral anticoagulant therapies; cost issues and some of the financial aspects of prasugrel and ticagrelor; social issues and medication side effects. But an important question arises is that whether switching between the various agents safe or not, and unfortunately the guidelines do not give any clear answer to this question. In other words, at present, data from large-scale clinical studies to guide the optimal approach to switching P2Y12 inhibitors are limited, and most data are derived from pharmacodynamic studies. In turn, practice guidelines have not fully elaborated on how to switch therapies, leaving clinicians with limited guidance on when and how to switch therapies when needed, which prompted the development of this expert consensus document, which I am using as a reference for my lecture today. Coming to the pharmacological properties, we know that the different agents have different pharmacological properties, and concerns surrounding the safety of switching between P2Y12 inhibitors have emerged because of the potential for drug-drug interactions. Drug-drug interactions are defined as modifications in the effect of a drug when administered with another drug. This may lead to a decrease or increase in the effect of the drug, and DDIs depends on some key pharmacological properties in turn. So, the effects of a P2Y12 inhibitors can be decreased, leading to inadequate platelet inhibition and increasing the risk of thrombotic complications. Alternatively, there may be potential for overdosing as a result of an overlap in drug therapy that could lead to excessive platelet inhibition and predispose to bleeding complications. Here are the important pharmacological properties of P2Y12 receptor inhibitors. This table shows the different pharmacological properties of the four available agents: clopidogrel, PRASUGREL, ticagrelor, and cangrelor. Starting from the mechanism of action, first we will discuss clopidogrel. So it is an irreversible receptor inhibitor. It has a prodrug. Half-life of the parent drug is 6 hours, and half-life of the active metabolite is 30 minutes. Binding site is ADP binding site. It is administered orally in a single OD dose. The onset of action is 2 to 8 hours, and the offset of action is 5 to 10 days, and it has cytochrome P450 drug interactions. Regarding prasugrel, it is also an irreversible receptor inhibitor. It has a prodrug, and the half-life of the parent drug is less than 5 minutes. Its distribution half-life is 30 to 60 minutes, and elimination half-life is 2 to 15 hours. It also binds to the ADP binding site. It is administered orally in an OD dose fashion, with an onset of action ranging between 30 minutes to 4 hours and offset of action 7 to 10 days. It has no cytochrome P450 drug interactions. With regards to ticagrelor, it is a reversible inhibitor. It has no prodrug. The half-life of the parent drug is 6 to 12 hours. The elimination half-life of this drug is 8 to 12 hours. And it has an allosteric binding site. It is administered orally in a BD dose fashion, with an onset of action 30 minutes to 4 hours, offset of action 3 to 5 days, and it has CYP drug interactions. Cangrelor is also a reversible receptor inhibitor. It has no prodrug, as it is given intravenously. The half-life of the parent drug is just 3 to 6 minutes. The active metabolite's half-life is not available, and the binding site is undetermined. It is administered intravenously. The frequency is continuous infusion, and the onset of action is approximately 2 minutes, and the offset of action is 60 minutes, and it has no cytochrome P450 drug interactions. Clopidogrel is second generation P2Y12 receptor antagonist, and prasugrel is third generation P2Y12 receptor antagonist. The other thing is that the active metabolite of clopidogrel is highly unstable, and it has a half-life of 30 minutes. On the other hand, the active metabolite of prasugrel is comparatively stable, and that's why the effect of prasugrel is can last up to 7 to 10 days, while that of clopidogrel might last 5 to 10 days. So here is an illustration of the mechanism of action of the different P2Y12 receptor antagonists. Prasugrel and clopidogrel are prodrugs, while ticagrelor and cangrelor have a direct action on the P2Y12 receptors. The resulting activation of the inhibition of these receptors leads to the cascade of events, which I'm not going into the details of that mechanism, but the ultimate result is platelet that are activated is being blocked as a result of the blockage of these receptors. And this is the offset of the antiplatelet effects of oral P2Y12 receptor inhibitors. Here we can see that the cumulative proportion of patients returning to baseline reactivity after the thienopyridine discontinuation, and this has been taken from the recovery trial. Baseline platelet reactivity, which was defined as within 60 P2Y12 reaction units of the reactivity measured before study drug exposure. So we can see that this is more for prasugrel. We can see here that the washout days are and clopidogrel still is there. So and this particular the offset of inhibition of platelet aggregation on ticagrelor, clopidogrel and placebo we can see here. So we can see that this is quite a bit difference between the two agents. Some of the switching modalities and what are the important definitions that you should be familiar with. Switching can occur between the oral agents and between the oral agent and the intravenous agent. The timing of switching with respect to the index event that led to the initiation of P2Y12 inhibitor therapy may also vary. Switching may cause drug-drug interactions between the two overlapped drugs. Switching is classified as acute within the first 24 hours of the initiation of the P2Y12 receptor antagonist, early, that is between after the first day and within 1 month, late, that is after the first month and before completion of the first year, and very late, that is beyond 1 year. So first we will be discussing switching between oral agents. Prasugrel and ticagrelor are characterized by enhanced pharmacodynamic effects compared with clopidogrel, and therefore switching between oral P2Y12 inhibitors may result in a variation from a less intensive to a more intensive agent, that is clopidogrel to prasugrel or ticagrelor, or vice versa from more intensive to a less intensive agent, that is prasugrel or ticagrelor to clopidogrel. These modalities of switching are defined as escalation and de-escalation respectively. Literature data comparing the pharmacodynamic effects of prasugrel versus ticagrelor have yielded some inconsistent findings. So the overall levels of P2Y12 inhibitors are mildly reduced and not that dissimilar between these agents. Switching between prasugrel and ticagrelor is referred to as change. Such terminology, that is escalation or de-escalation and change, should be considered only when referring to the pharmacodynamic effects associated with switching and should not imply any clinical correlate, that is efficacy or safety. That is known to you that prasugrel and ticagrelor have enhanced pharmacodynamics compared to clopidogrel. and that's why switching may result in variations from a less intensive to a more intensive effect or vice versa. There are two different classes of P2Y12 inhibitors, that are thienopyridines and cyclopentyl-thiazolopyrimidine. These are the two different classes, and if these are switched, this is referred to as interclass switch, and this may also result in drug-drug interactions. Generally, escalation is not associated with drug-drug interactions, but can be associated with de-escalation, particularly when ticagrelor is replaced with clopidogrel. Okay, so what is escalation? Escalation is switching from clopidogrel to ticagrelor or prasugrel. That is, you are switching from a less potent to a more potent agent. This is an example of interclass switch, and generally it is thought that this type of switch has no drug-drug interactions. When coming to de-escalation, this is referred to as switching from prasugrel or ticagrelor to clopidogrel, and it's another example of interclass switch which has potential drug-drug interactions, particularly if switched from ticagrelor to clopidogrel. And change is referred to as switching between prasugrel and ticagrelor. It's another example of switch, and it has potential for drug-drug interaction, particularly if ticagrelor is switched to prasugrel. So always keep in mind that switching from a less potent to a more potent drug will not result in drug-drug interactions, and switching from a more potent agent to a less potent agent, for example from prasugrel or ticagrelor to clopidogrel, or from prasugrel to ticagrelor, may result in potential drug-drug interactions. Coming to the switching between oral and intravenous agents, bridge is defined as switching from either oral agents to cangrelor, and it's an example of interclass switch with no potential for drug-drug interaction. And transition, on contrary to bridge, is referred to as when cangrelor is switched with any of the oral agents, and it has potential for drug-drug interactions, particularly when ticagrelor is switched to cangrelor. Escalation, that is switching from clopidogrel to ticagrelor or prasugrel. Trials have consistently shown enhanced platelet inhibition with escalation, and these effects are achieved more promptly after giving loading dose compared with a maintenance dose. When is escalation required? Acute coronary syndrome patients planned for PCI already pre-treated with clopidogrel, patient transferred to PCI capable hospital, occurrence of acute coronary syndrome while the patient is on clopidogrel, ST elevation MI, in-hospital reinfarction, younger patients, patients who have higher BMI, and high-risk angiographic characteristics. Some of the trials that I will recommend you to look at are the SWAP and the RESPOND trials. And this is again the placebo loading dose plus clopidogrel, and placebo loading dose plus prasugrel, and prasugrel 60 mg loading dose plus 10 mg maintenance dose comparison, and it is compared with the maximum platelet aggregation. So again, de-escalation is switching from prasugrel, ticagrelor to clopidogrel. When it is done, sometimes the cost associated with generic clopidogrel is less compared to that of ticagrelor and prasugrel, so that's one of the reasons. Potentials for increased bleeding risk with ticagrelor and PRASUGREL over a period of time, particularly if they are used for more than 1 year. And the other indication might be dyspnea with ticagrelor. If a patient has a stroke or transient ischemic attack, patient who have a BMI or a body mass index of low body mass index and a weight less than 60 kg, these patients are generally de-escalated. Or if they have contraindication in the first place. When it is done, that's already we have mentioned, that is in older patients, patients with low BMI, patients who have a transient ischemic attack or had an ischemic or hemorrhagic stroke, in-hospital CABG, patients who have in-hospital atrial fibrillation or atrial flutter, and patients who are on oral anticoagulant therapies. Topic trial which showed that de-escalation after 1 month from an acute coronary syndrome when the patient is event-free leads to reduced bleeding complications. So that is one of the evidence in favor of de-escalation. Change, that is switching between PRASUGREL and ticagrelor. Why it is done? One thing is that ticagrelor is given in a 90 or 60 milligram BD dose while PRASUGREL is given in an ORD dose. So that's one of the advantage that we want to exploit that advantage, we want to use it. And the other is that if you want, on the other hand, if the patient is on ticagrelor and he develops ticagrelor associated dyspnea, so we will definitely try to switch that, change ticagrelor with PRASUGREL, and if the patient has some contraindications to the use of PRASUGREL. The evidence is from SWAP-2 and SWAP-3 trials. And again, this is just some of the statistics that here are displayed. Bridging is basically changing or switching from oral agents to cangrelor, and the evidence comes from the bridge trial in which patients on thienopyridines undergoing cardiac surgery bridging with the cangrelor resulted in more sustained platelet inhibition, and there was no drug-drug interactions with this approach. So coming to the expert consensus recommendation on switching, in line with the limited safety and efficacy data in this field, these recommendations are to be considered mostly consensus-based rather than evidence-based. In general, switching approaches that have shown to be associated with the DDIs should be avoided or minimized unless clinically necessary. The provided recommendations are to be considered as guidance for the practicing clinician who may consider alternative approaches based on clinical context of the patient. The considerations made here are proposed under the assumption that these patients are also, for the most part, treated with concomitant low-dose aspirin in line with the guidelines recommendation. So, escalation in the acute or early phase is done with the use of a loading dose of ticagrelor or PRASUGREL. That is, within the first month, if a patient needs escalation, you should give a loading dose of ticagrelor or PRASUGREL followed by a maintenance dose. Irrespective of the timing and dosing of clopidogrel, however, it should be kept in mind that the dose should be given at least 24 hours after the last maintenance dose of clopidogrel. While if you have to do escalation during the late and very late phase, that is beyond the first month, just use the maintenance dose, no need for loading dose in that case, and this is done 24 hours after the last dose of clopidogrel. Escalation from clopidogrel to prasugrel or ticagrelor in the early, particularly acute phase of treatment should occur with the use of a 60 or 180 milligram loading dose respectively. That's 1 point. And administration of an LD regime, that is loading dose regime, may occur regardless of the timing of the last dose of clopidogrel. However, 24 hours from the last dose of clopidogrel is generally considered a safe period to avoid any bleeding complications. Recommendations are mostly consensus-based rather than evidence-based, and patients are assumed to be on low-dose aspirin therapy. De-escalation is done again if the patient requires de-escalation during the acute and early phases of their primary condition. Loading dose of clopidogrel 24 hours after the last maintenance dose of ticagrelor or prasugrel. And with prasugrel we can de-escalate without a maintenance dose as well. So if the patient is de-escalated with ticagrelor, clopidogrel, the patient can have a loading dose. While on the other hand, if the patient is de-escalated while on prasugrel, we can even de-escalate with a maintenance dose as well. Beyond the acute and early phases, during the late and very late phase, maintenance dose of clopidogrel at the time of the next scheduled dose of prasugrel, and for ticagrelor use a loading dose of clopidogrel 24 hours after the last maintenance dose. If the reason behind de-escalation is bleeding, avoid use of loading dose if possible and start with a maintenance dose of clopidogrel instead. Change. Use loading dose prasugrel if you are switching from ticagrelor regardless of the phase, whether it's acute, early or late. A waiting period of 24 hours should be observed. In general, during the acute phase, switching with a loading dose might be reasonable 24 hours after the last dose, while during the late phase, switching with a maintenance dose 24 hours after the last dose may be reasonable. So you can switch with a loading dose if the patient requires change during the first 24 hours, and beyond 24 hours just switch with a maintenance dose. Don't give a loading dose. So this is the switching between oral P2Y12 receptor inhibitors. This is the acute phase, that is the first 24 hours or beyond the first day to the first month, and we can see that if you need escalation with prasugrel from clopidogrel, then give a prasugrel loading dose irrespective of the timing and dosing of clopidogrel. And if you have to de-escalate from prasugrel, then you have to give a loading dose of clopidogrel 24 hours of the last prasugrel dose. If you have to escalate from clopidogrel to ticagrelor, give ticagrelor's loading dose of 180 milligram irrespective of timing and dosing of clopidogrel. On the other hand, if you have to de-escalate from ticagrelor to clopidogrel during the acute phase, you should be giving loading dose clopidogrel 600 milligram 24 hours after the last ticagrelor dose. In contrary, we can see that the change between the two agents, ticagrelor and prasugrel, during the acute phase happens with the loading dose 24 hours after the last dose of either agent. During the late and very late phases, if you have to escalate from clopidogrel to prasugrel, just give 10 milligram maintenance dose 24 hours after the last clopidogrel dose. On the other hand, during the late phase, if you have to de-escalate from prasugrel to clopidogrel, give clopidogrel 75 mg maintenance dose 24 hours after the last prasugrel dose. On the other hand, if you have to escalate from clopidogrel to ticagrelor, you have to give ticagrelor 90 mg BID maintenance dose 24 hours after the last clopidogrel dose. And if you have to de-escalate from ticagrelor to clopidogrel, give clopidogrel 600 mg loading dose 24 hours after the last ticagrelor dose. And during the very late phases, if you have to change between ticagrelor and prasugrel, you have to do this with a loading, only the maintenance dose is given if you are switching between prasugrel and ticagrelor. And if the change is from ticagrelor to prasugrel, give prasugrel loading dose 24 hours after the last ticagrelor dose. What is bridging? We already discussed. So a waiting period should be observed after discontinuation of the oral agents. 3 to 4 days for prasugrel and 2 to 3 days for ticagrelor and clopidogrel to minimize the duration of cangrelor infusion. Transition. Cangrelor infusion is started before PCI and continued for at least 2 hours or till the completion of the procedure, whichever is longer, for up to 4 hours. 4 hours infusion in patients treated with primary PCI or have received opiates. If thienopyridines are to be administered, use a loading dose at the time when cangrelor infusion is discontinued. FDA states that ticagrelor can be given before, during, or after the infusion of cangrelor. Early administration of ticagrelor might be considered. So here is the consensus recommendations on switching between oral and intravenous P2Y12 inhibitors. So coming to this part, the A part, that is bridging from oral to intravenous agents. For both cardiac and non-cardiac surgery, if withdrawal of P2Y12 inhibiting therapies is required, clopidogrel and ticagrelor are stopped. Prasugrel is stopped 7 days, clopidogrel and ticagrelor are stopped 5 days, cangrelor is started at 3 days, and it is stopped approximately 1 to 6 hours before the procedure. Cangrelor is reinitiated and follow up until discharge. So it is reasonable to start cangrelor bridging up to 3 to 4 days after prasugrel discontinuation and 2 to 3 days of clopidogrel and ticagrelor discontinuation. Okay, so this should be clear to you now. We are giving cangrelor to the patient at a dose of 30 mics per kg bolus and 4 mics per kg per minute infusion. Clopidogrel is administered in a loading dose of 600 mg immediately after discontinuation of the cangrelor infusion. Prasugrel, on the other hand, is administered immediately after discontinuation of cangrelor in a loading dose of 60 mg, and ticagrelor 180 mg at start of cangrelor infusion up to immediately after discontinuation. So that's a bit few points that you need to remember. When to stop prasugrel, when to stop clopidogrel and ticagrelor, when to resume IV cangrelor, and when to stop cangrelor before surgery and then to resume it, and when to reinitiate the oral agents. So the transition and bridging is quite well summarized in this particular slide. Coming to some special considerations. First, we will be discussing patients undergoing cardiac and non-cardiac surgery. Acute coronary syndrome patients undergoing CABG, unless recent PCI was done, stop P2Y12 receptor inhibiting therapies pre-op and restart post-op, as we already discussed in the previous slide. CLOPIDOGREL and TICAGRELOR are stopped 5 days and PRASUGREL is stopped 7 days before surgery. If bridging with cangrelor is intended, wait 3 to 4 days after discontinuation of PRASUGREL and 2 to 3 days after ticagrelor or clopidogrel discontinuation. Post-operatively, clopidogrel is started with a loading dose as soon as the bleeding risks allow. And PRASUGREL and ticagrelor administration should be discouraged in the early post-op period after major non-cardiac surgery. Post-op bridging with an intravenous agent should be considered if clopidogrel per oral is not possible. Second, patients with bleeding or high risk for bleeding complications. Patients on dual antiplatelet therapy who develop a bleeding complications might be de-escalated. Also, patients who are at high risk of developing bleeding complications, such as patients who develop thrombocytopenia or cerebrovascular events or who are elderly. In this case, a 75 mg maintenance dose of clopidogrel might be started. A 300 mg loading dose of clopidogrel should be given if there is a gap of at least 5 days. Patients who received thrombolytics. If dual antiplatelet therapy is indicated after thrombolytics, clopidogrel is the agent of choice as per the guidelines. Escalation should not be attempted within at least the first 24 hours because of an increased risk of bleeding. Beyond 24 hours, escalation should precede a loading dose of ticagrelor or PRASUGREL. Patients on oral anticoagulants. If a patient who is on oral anticoagulant and is undergoing PCI, clopidogrel is the P2Y12 receptor inhibitor of choice. De-escalation is recommended when the patient who are post-PCI on potent agents now develops atrial fibrillation that requires oral anticoagulants, and a clopidogrel maintenance dose of 75 mg is generally considered safe in these patients. In P2Y12 inhibitors naive patients, patients with atrial fibrillation and on oral anticoagulants start with 600 mg loading dose of clopidogrel. So this is the difference between the two groups. In naive patients, give a loading dose, and on the other hand, if the patient had some sort of increased risk for bleeding or AF or things like that, just proceed with a maintenance dose. Patients undergoing very late switch, that is beyond 1 year. De-escalation should occur with a maintenance dose. Ticagrelor 60 mg BD for post-MI patients after 1 year of index event. A switch should be made to 60 mg BD maintenance dose without a loading dose. If a patient presents with unknown medications, sometimes patients present to us that they are taking medications but they don't know what medications. They should be treated as naive patients and a loading dose should be used. So I guess we are coming to the end of our topic and some of the important take-home points. There are specific indications for the available P2Y12 receptor inhibitors. We know that clopidogrel can be used even in ACS, apart from ACS patient, in stable ischemic heart disease patients as well. Clopidogrel and PRASUGREL are indicated specifically in acute coronary syndrome patients and are preferred over clopidogrel. And clinical circumstances may arise that require switching. We already discussed in detail. Robust data is lacking on specific switching strategies. So many factors should be kept in mind, such as the pharmacodynamics and different agents, of the different agents, so that drug-drug interactions are avoided, which is the main reason and a focus of concern when we are switching these therapies. Recommendations here are derived from pharmacodynamic and registry data and integrated with an understanding of the pharmacologic principles of the agents involved. Thank you for your attention, and thank you for watching. If you are interested in cardiovascular education, please do subscribe to this channel. We will be coming back with some more interesting educational material soon. Till then, goodbye.